500 micrometers are usually closed with standard internal limiting membrane peeling. Holes up to 800 micrometers are treated with an inverted flap. Even when the inverted flap, it is not always possible to achieve an ideal foveal flow. For example, in macular holes of 775 micrometers may result in a W-shaped closure, which we consider an unsatisfactory anatomical outcome. We are developing alternative method to achieve more complete anatomical restoration. In Russia, autologous conditioned plasma is widely used. ACP is a platelet-rich plasma obtained by centrifuging the patient's venous blood for 5 minutes at 1,500 revolutions per minute. The platelet-rich fraction above the red blood cells is used for surgery. For relatively small macular holes up to 535 micrometers, we perform standard 25 vitrectomy with ILM removal, apply a few drops of ACP, and finish with a tampon. On OCT, after a few days, we can see a fibrin plug, and after 9 months, the macular profile is completely restored. You can see the ellipsoid zone and the external limiting membrane are clearly visible. For macular holes larger than 535 micrometers, close may vary. We may observe U-shaped, V-shaped, or W-shaped closure when a gap W-shaped when a gap remains between the edges. Therefore, we search for a technique that allows tighter edge apposition and more complete restoration. For macular holes up to 800 micrometers, we develop a combined approach. Perform vitrectomy and ILM peeling, introduce perfluorocarbon liquid. We use passive aspiration to remove fluid from the hole and bring the edge together. Under intraoperative OCT control, we inject ACP to fill the hole and gently aspirate excess ACP to seal the edge. We remove PFCL and finish with air tamponade for reliability. The patient remains face down during the first postoperative day. This slide demonstrates the key surgical steps performed under intraoperative OCT control. To evaluate effectiveness, we compared two groups. 40 patients were treated with convergence plus ACP group 1, and 40 patients were treated with ACP alone, 2 group. Baseline characteristics such as age, macular hole size, and best corrected visual acuity were comparable between the group. We evaluated how ACP filled the hole. In the convergence group, you can see ACP spread evenly into the macular holes. In the ACP only group, it often remained on the surface and doesn't spread into the macular hole. We also evaluate retinal layer correspondence. On the left side, we can see a U-shaped closure with complete retinal layer correspondence. On the right, closure is also U-shaped, but the retinal layers are not aligned. After 1 month, there were no significant differences in the best corrected visual acuity between the groups. However, in the ACP-only group, 15% of patients had reopening of the macular hole and all required reoperation. In the convergence plus ACP group, no recurrences were obtained. After 6 months, best corrected visual acuity remained similar in both groups. However, complete retinal layer correspondence was observed in 57.5% of eyes in the convergence group versus 17% in the ACP-only group. The platelet clot persisted more often in the convergence group, providing better mechanical stability, in our opinion. After 12 months, the differences became significant. In the convergence plus ACP group, group 1, 70% of eyes showed U-shaped closure with complete retinal layer correspondence, and a mean best corrected visual acuity of 68 letters. In the ACP-only group, group 2, complete retinal layer correspondence was observed in only 17% of eyes with a mean best-corrected visual acuity of 49% letters. In most patients, the ACP clot dissolved within 1 year. Let me show two clinical examples. The first example shows a patient with the macular holes of about 600 micrometers treated with only ACP. Despite adequate ACP application, U-shaped closure was not achieved. And the second example shows a patient with a similar macular holes diameter treated with our technique. Follow-up OCT demonstrates good U-shaped closure, restoration of the outer retinal layers, and marked improvement in the best-corrected visual acuity. Thus, ACP combined with edge convergence provides better anatomical outcomes for macular holes up to 800 micrometers. Intraoperative OCT remained an essential tool for real-time monitoring and surgical decision-making. But the most challenging macular holes from the surgical perspective are those larger than 800 micrometers. In the CLOS 2023 classification, they are called XX large, and those over 1000 micrometers are termed giant. Now I will explain how we treat holes larger than 800 micrometers. Autologous retinal transplantation, IRT, was first performed by Dilraj Garwal in 2015. This technique involves transplanting a piece of patient's own peripheral retina tissue. According to the original authors, is effective for holes of any size. When the diameter is greater than 800 micrometers, we choose this approach, often combining it with autologous conditioned plasma. A key factor for success in IRT is precise marking of the donor graft. We developed a precise marking method using the Navilas navigation system. First, we perform OCT angiography. Then the image is exported to the Navilas laser unit, where a circle of the required size is generated based on this scan. This circle is projected onto the peripheral retina, and the laser marks the future donor site. Such navigated marking allows us to cut a graft of the exact size and shape, avoiding overlap of shortage. This slide shows scanning laser ophthalmoscopy before and after marking. The marking is clearly visible as a white circle. The video demonstrates the surgical procedure. I'm sorry. Central vitrectomy and ILM peeling. Diathermy around the marked donor area. Cutting the donor graft strictly along the marked circle and transferring into the macular hole. Introducing autologous plasma for fixation and monitoring its polymerization on OCT. Note the hyperreflective line on the surface of the retina and graft. A 5 minutes waiting period and position control on IOCT. Fluid air exchange and gas tamponade. Perfluorocarbon liquid is not used here. Let me demonstrate a clinical example. The patient had a macular holes larger than 1000 micrometers and an initial visual acuity of 29 letters on the 80DRS chart. This is a surgery video. It shows intraoperative IOCT monitoring of graft position. You can also see the film on ACP forming over the graft. The next day OCT shows that under gas tamponade, the graft is in the correct position and the edges of the hole under the transplant retina have come together to 739 micrometers. In our series of patients, 10 eyes, all holes were larger than 800 micrometers, with the largest about 1100 micrometers. Half of the patients had refractory holes after previous closure attempts. Component was performed with air, hexafluoroethane gas, mixture, or silicone oil. All patients' visual acuity improved, and this improvement was maintained for 6 months. Fundus microperimetry shows a shift in the fixation point in some patients at 6 months. This is not because the graft itself gives vision, but because of improved microenvironment in restored function at the edge of the hole. Our experience shows that layer by layer integration provides the most stable fixation point and the highest retinal sensitivity. Visual acuity tends to be higher compared to the overlapping or step-like configuration. This may be explained by presence of an uncovered fixation point at the edge of the defect in layer-by-layer integration. Whereas in overlapping configurations, the fixation zone is covered by retina tissue. Therefore, accurate graft sizing is critical. In conclusion, ECP combined with edge convergence provide better anatomical outcomes for macular holes up to 800 micrometers. Intraoperative OCT remains an essential tool for retinal time monitoring and surgical decision-making. Autologous neuroepithelium transplantation is an effective method for closing macular holes larger than 800 micrometers. Key success factors include precise marking of the donor site using the Navilas navigation system, accurate graft excision, fixation with autologous plasma, and IOCT monitoring of graft position. I would also like to invite all of you to the 5th International Scientific and Practical Education Forum, Ophthalmogerontology Innovative Solution, which will take place on May in Moscow. Thank you.
Спасибо вам большое, доктор Денис. Спасибо за invitation. Я думаю, мы встретимся с вами в Москве, иншаллах. See you later.
Хорошо.
Bye. До свидания.